Okay. Good evening, everybody. This is 2026 CSI PG Track program under Dr. Kamal, who will be guiding this PG Track program for this year. Initially, we'll be doing it online, and later on, we will also have a physical in-person PG Track program. Now, Kamal, I must congratulate you for taking up this onerous responsibility of conducting this thing, arrangement, everything. And I think all the students will learn and be benefited from this PGTech program. With these few words, Kamal, I hand over to you, and please continue with your program.
Thank you, sir. Good evening, everyone, dear students and dear respected faculty. It's a pleasure and indeed a big initiative by Headquarters CSI that has actually gone ahead with this teaching program of its own with complete support, with pure educational purpose. And it's an honor to have our patrons, our President-elect CSI, Dr. Satyendra Tiwari, our Honorary General Secretary, Dr. D.P. Sinha, our expert for the day, and faculty and examiner, Professor S. Ramakrishnan, my friend from AIMS, Delhi. Along with me, who I've been given a responsibility of PG Track CSI for this program. I have been guided and supported by my committee members, Dr. Mohit Gupta, professor from GB Pant, Delhi, who's also traveling, Dr. Majan, professor KEM, Mumbai, Dr. B.H. Natish from Bangalore, who will be doing the next CSI meeting, Dr. Professor B.P. Chattopadhyay from Kolkata, and Dr. R.K. Singh from Bhopal. So, good evening, everyone. Welcome to this session. And we have actually planned out to do these meetings every fourth Saturday in consecutive fashion. 5 important clinical cases that are commonly asked in exams. That's what we intend to cover. First of them is the most common long case that is often asked is a multivalvular case. And for that to present, I have a third-year resident from Mehta Institute of Cardiology, Dr. Arjun. So Dr. Arjun Lal will be presenting a long case of approach to multivalvular. And all our faculties are the esteemed panelists who've joined today, Dr. Professor Ramakrishnan, who will be then later on teaching us and taking us through for next 20 minutes. So can I have the agenda, please, rolled up? So this is how the agenda for the day is. We want to end up on time. So the case presentation begins with Dr. Arjun Lal, who will be presenting a case on approach to multivalvular heart disease. And all of us, Dr. R.K. Singh, Dr. Rama, myself, and Dr. Marjan, who's joining, and all of us will be the examiner, with expert examiner being Professor Dr. Ramakrishnan. After his around 50 minutes of case presentation, we'll have expert talk as to clinical examination approach. We'll focus to a case of multivalvular heart disease, and then some discussion and word of thanks. So, Dr. Arjun, if you can start. Dr. Ramakrishnan, welcome to you. Thank you. You have always been there to help us and guide us whenever there has been a need with PG program. Dr. Ramakrishnan.
Thank you. Thank you for the opportunity. You can straightforward go to the case presentation.
Yes, Dr. Arjun, if you can start sharing and start presenting your case.
Yes. Good evening, respected faculty. Good evening, all the members. I'll just be sharing my screen, sir.
So very often when the case presentation
audible,
is
sir?
done, yes, you are completely audible.
Yes.
Now we can see your screen. If you can make it full screen and start presentation.
Yes, sir.
So
I've made
this
it
is the
full
commonest
screen, sir.
case, and yes, this is not full screen. You can click on the lower part and make it full screen, Arjun. So yes, please go ahead.
Yes, sir. Good evening, sir. I'll start with the case, sir. My case is of Mrs. DV, 68-year-old female, vegetable vendor by occupation, resident of Patan, Gujarat. She's not formally educated. The history is given by the patient herself and her son and appears to be reliable. She is presented to the hospital with the chief complaints of progressive dyspnea on exertion since 3 years, intermittent palpitations since 2 years, and dizziness on exertion since 1 week. The patient was apparently asymptomatic 3 years back and used to perform her daily activities, which involved lifting heavy loads and climbing stairs, with ease. She then started complaining of dyspnea on exertion. It was gradual in onset and progressive in nature. Initially, she felt breathless on carrying heavy loads for some distance, which over a period of 1 year progressed to breathlessness on climbing stairs. Around 2 years back, she had an episode of increased breathlessness with dry cough, which lasted for a few days and resolved only after admission and receiving some IV medications. During this episode, she also had breathlessness and coughing on lying down straight on the bed, which resolved after medication. At this time, she was told to have some heart disease and was advised surgery, but she continued on oral medications. Over the next 2 years, her dyspnea gradually worsened and she decreased her activities, avoided lifting heavy loads or walking long distances. However, there was no dyspnea at rest or with daily self activities. 5 days back, she had increased dyspnea with palpitations and sweating while walking, which did not resolve even after resting and required hospital admission. It was finally reduced after medications. She has never had complaints of chest pain, PND, pedal swelling, or abdominal distension. There is no complaint of chronic cough, wheeze, or seasonal variation in breathlessness. No complaints of blood in sputum or any hoarseness of voice. The patient also complained of intermittent palpitations since 2 years. The palpitations are felt as rapid heart rate with irregular in rhythm and often missing on some beats. Initially, it was felt after exertion and it decreases at rest. They were first noticed 2 years back when she had worsening dyspnea, which required hospitalization. Initially, this palpitation was felt with heavy exertion gradually increased to palpitations on walking on a level road for longer distances since past 1 year. The palpitation gradually decreases after 5 to 10 minutes of rest and is never felt at rest or at night during sleep. 5 days back, she had this increase in palpitations, which persisted even after stopping work and was associated with sweating, breathlessness, and dizziness. The palpitations have never been associated with any episode of loss of consciousness, any blackout or fall, no abnormal body movements, no increase in micturition frequency, no chest pain. They have never been associated with any transient or permanent weakness in any of the limbs or slurring of speech.
So, can you differentiate from the history of palpitation as to what probably is the etiology? So, what are the specific symptoms that yield some specific morphology of arrhythmia or palpitation that you're dealing with?
Yes, sir. So, historically, first thing, whenever I have a history of palpitations, I want to differentiate whether they are arrhythmogenic or volumogenic. So, I will look at.
You call volumogenic palpitation as palpitation, or they'll be more represented by what is called as increased precordial activity that patient may. So, how are the
Yes,
two
sir.
symptoms different? What is the description difference? How do you elicit that from a history in a patient with increased precordial activity? And where do you find that?
Yes, sir.
Which kind of disorders you find that?
So increased precordial activity can be felt as palpitations by patients. They are found in patients who have volume overload or high output states in certain valvular heart diseases, also like aortic regurgitation or mitral regurgitation. In volume overload states like anemia or thyrotoxicosis, they can be seen. And the description is usually that a thumping of heart sounds, which is regular and increases on exertion and after exertion, and then decreases gradually with rest. They are gradual.
Athlete, when you run a marathon, you'll get some precordial activity, won't you? You'll get
Yes,
some
sir.
palpitation. So, is it physiological, or you'll
So
consider that also as a symptom?
that will be physiological, sir. It will
How
be
do you differentiate that?
the
What
first thing.
what sets it apart?
First of all, sir, lesser exercise capacity will be there. Like patient will have these
So
symptoms.
accustomed, right? So
Yes, sir.
indirectly, examiner is trying to ask you accustomed word. What
Okay.
is for a marathon runner's symptom is not something that I or you have, right?
Yes,
Yeah,
sir.
for me and you to run a half a mile also may cause palpitation. For a marathon runner, he may not have. So what is accustomed for you? That's how the classifications go. So your
Yes.
answer should come as to what are the standard classification and try to bring us to that kind of a viva where you are commonly prepared. But more importantly, what I was trying to elicit was certain histories have been used to differentiate certain types of arrhythmia. One of them is like bending forward, which now Brunwald also mentions. Trigger of an arrhythmia when bending forward is usually associated with what arrhythmia? Palpitation that are triggered by bending forward, usually in SVT.
Okay. Yes, sir.
SVTs can be triggered by bending forward. Any other arrhythmia that you know that can be triggered or terminated? So SVTs can be terminated by.
Terminated. Uh, by certain vagal maneuvers, sir, by carotid sinus massage, or by cold water application, certain cold water application, by Valsalva, they can be terminated.
So what is modified Valsalva maneuver? Of all the vagal maneuvers, there are 6 maneuvers, 6 photographs in Brunwald's textbook of cardiology in one page in an illustration. So out of the 6 maneuvers, which of them is having the highest yield? Any study that you know of?
I'm not
What is
aware of
modified
the study,
Valsalva?
sir.
Sorry?
Not aware of the study, sir.
So modified Valsalva, you can go through that.
Yes,
And
sir.
also there are certain modified diving reflex, all of them. So the leg raising for 30, 40 seconds and that suddenly asking the patient to sit up, that also can terminate. That probably has the highest yield in terms of bending forward. Any other symptom that you know of that can you be reminded of? What is that symptom?
Bendopnea is one of the symptoms,
Bendopnea.
sir. Yes,
Correct.
sir.
So bendopnea, what does it represent? What does it is a prognostic, a diagnostic, or what is it? What does it usually yield? And what are the new publications as recent as 2025 about bendopnea? So for a student who otherwise can examiner can make out that some routine symptoms you are able to pick up, you may be asked about what is recent update, and that's the whole idea of doing, because we all have been part of multiple teaching programs. We all want to ask you something beyond that's already known. So we'd expect you to know something that's late breaking or something new. What is BOSSI? Bendopnea Oxygen Saturation Index.
Okay, sir.
So this is an index which has come from an Indian institute, from Nizam Institute. It's a published paper, very interesting. Go through it. It basically is looking at saturation and hemodynamic studies in patients on bendopnea. And it tells you that actually patients do desaturate when you bend forward. And there are this is from Nizam Institute, Hyderabad, that their paper is published, and they've looked at the saturation difference between a patient who's bent forward. And so bendopnea, it's an equivalent of what grade 2 or 3 or 4 class.
It suggests heart failure, sir. Only class
And
3.
so what does it equate to? Filling pressure, wedge pressure, LVEDP, EF. What is it has shown to be best correlating with which hemodynamic parameter? Bendopnea.
It's
Best correlates with filling pressures.
filling pressure. Yes, sir.
Yeah, best
So Arjun,
correlates, and it's
can
usually sorry,
Yes, sir.
please.
yeah, can we have a bendopnea in IPH?
In IPH, sir.
Yeah.
Um,
So it's a very important concept wise. Like for example, as sir pointed out, filling pressure is very important.
yes.
The other important correlate that has is a low cardiac output. So primarily it can happen in IPH also. Bendopnea has been described in IPH. So there you cannot classically correlate with your increased pulmonary capillary wedge pressure. So that there it correlates with the low cardiac output. So regarding your symptom of volumogenic palpitation, the other classical symptom which may sometimes patient may elicit is commonly it is well perceived in a quiet room, like it's like your examination palpitation, like. And then generally when they lie down in a quiet room, so if they turn into the left lateral position, they are better appreciated. So these are the other pointers that you can add to your differentiation.
Yes, sir. Right, sir.
One.
Yes.
So
sir.
with these symptoms of triology that you mentioned,
Yes, sir.
palpitation, dyspnea, and blackouts, right?
Yes, sir. Dizziness is there, sir, but there is no history of blackout or fall. And dizziness is a very recent symptom in this patient, sir. Since 1 week, the patient has been complaining of dizziness on exertion on walking for a few steps. This felt as lightheadedness on exertion is relieved at rest after a few minutes. And it is usually in association with with her palpitations, but she has never had any blackout or fall or abnormal body movements or any dizziness immediately after getting up from the bed.
And this whole duration is how many years?
The symptoms of dyspnea have started 3 years back.
So 3 years of dyspnea in a elderly female. What is
Yes,
the
sir.
differential that points to? So what are you looking at? So
Let
assuming.
me complete the history, sir. Like let him complete the
Okay,
history.
okay.
Sir.
Please go ahead, finish it. I think I thought that he has done all the symptoms. Go ahead.
Yeah.
Yes, sir.
Go ahead.
Since past few months, she also complains of early satiety, but there is no abdominal pain, abdominal bloating, pedal swelling, or abdominal distension, and there's never been complaints of any low-grade fever, weight loss, or sleep disturbances. Admission has been only once before 2 years back, wherein the symptoms had resolved with IV medications, and she was prescribed oral medications which she has taken infrequently, and was advised surgery which she declined. In past history, it is significant for at around age of 16 years, she had an episode of multiple joint pains with fever, which lasted around 1 month. It improved, required admission and improved with some IV and oral medications. It was,
For
however, not
1 month or joint pain 1 month?
it was a joint pain. And it was not associated with sore throat or cough or breathlessness, chest pain, any skin lesions or skin rash, not associated with any burning micturition or redness in eyes or any morning stiffness, or there was no residual deformity. She is not a known case of any of diabetes or hypertension. She has no addictions, no history of tuberculosis or TB contact in the family. No other family member has a similar history or history of any sudden cardiac arrest or heart disease. She has two children, both born of uncomplicated pregnancy course and normal vaginal delivery. She has been infrequent with her oral medications and has never been prescribed any once monthly IM injections. So that is my history, sir.
Yeah, so summarize your history.
Yes, sir. To summarize, my patient is a 68-year-old woman, vegetable vendor from rural Gujarat with no formal education, and she has presented with progressive exertional dyspnea advancing from NYHA class 2 to class 3 over 3 years, exertional irregular arrhythmogenic palpitations for 2 years, and exertional dizziness since 1 week, with an episode of acute decompensation 2 years back and acute worsening to NYHA class 4 since 5 days, all on the background of a past history suggestive of acute traumatic fever in childhood.
What possibilities you want to consider?
Sir, for on the basis of history, sir, I have kept these differentials, sir. My first differential is a rheumatic etiology, left-sided stenotic lesion, most probably severe mitral stenosis with atrial fibrillation. The second differential that I have, the points that I think are favorable in the first differential is that the patient has had complaints predominantly of breathlessness at the start, and some duration of symptoms are there, and with irregular palpitations that would be because of atrial fibrillation. And sir, she has also had early satiety that might indicate some right heart failure symptoms also. So that is my first differential, sir. The second differential that I've kept is mixed rheumatic severe aortic stenosis with mitral stenosis.
So Arjun, when you are asked differential, you should. So I would say that your 1, 2, and 3. So differentials are, one is etiological, second is pathological, right? So etiologically, 1, 2, and 3 is nothing but rheumatic heart disease.
Yes,
That's
sir.
one differential.
Yes, sir.
So the second differential that you're putting is restrictive. But don't you think that what is her age?
Degenerative. Yes, sir.
Yeah, no, what is her age?
She is 63-year-old female.
Why not ischemic heart disease? I
Yes,
said
The
this
most
is
common
ischemic
that
heart
you will
disease.
feel will be this ischemic heart disease, 68-year-old. I thought you said 68. 68, first thing that should come to your thing should be ischemic heart disease, heart failure, either with reduced ejection fraction or preserved ejection fraction. Those will be far more common than your rheumatic heart disease. Okay, agreed. You had a history suggestive of acute rheumatic fever in the
yes,
past,
sir. Yes,
but
sir.
that is way down the line.
Yes, sir. Okay, sir.
So, what are the causes of dyspnea in ischemic heart disease?
Dyspnea and ischemic heart disease can be caused by the low cardiac output state, sir, because of either
Most common cause is MI-LV dysfunction.
MI. Yes, sir.
In the absence of MI-LV dysfunction, what are the other causes? When dyspnea can be the predominant manifestation of ischemic heart disease?
When there is a complication of ischemic, like acute MI, like acute
She never had
mitral
acute
fibrillation.
MI. She never had an
Yes, sir.
acute MI. This is chronic heart failure,
Yes, sir.
chronic problem. So, what are the causes like?
Heart failure with preserved ejection fraction can also be there, associated with chronic coronary artery disease, sir. So that can
One
cause.
that could be like a diastolic dysfunction that is well known to happen with coronary artery obstruction. That is well known. Okay, then what else?
Um,
What is anginal equivalent?
Yes, sir. Dyspnea is one of the angina equivalents.
So which
Yeah,
are
more
the
common.
group of patients who are known to have anginal equivalents more commonly? Other than typical
Elderly
angina,
female, sir.
elderly female. So that's a 68-year-old. She can very well present with dyspnea.
Yes,
One
sir.
more reason that you should not forget will be ischemic MR.
Yes, sir.
So these are the causes when predominantly patient can present with dyspnea.
Right,
So
sir.
that should be your number one diagnosis, maybe number two diagnosis, because she had history of acute rheumatic fever.
Yes, sir.
So why this is not idiopathic PH? Sir said this can be, IPH. Can it be IPH? Why not?
Uh, Idiopathic PAH does have symptoms of dyspnea, sir, but it also has symptoms of chest pain. It will have right heart failure symptoms, which will be predominant in my patient. Did not never had complaints of pedal swelling or abdominal distension. Right heart failure symptoms are not that predominant in this patient. So probably that puts it. That is
Age?
one against.
What is the
Age
age?
is also
Yes, sir.
important.
Age
Onset of
is
symptom?
very elderly. Yes, sir. Usually would present at much earlier age.
And duration?
So
Yeah. Please go ahead, sir.
So, how often you find a history of acute rheumatic fever in a patient with MS or in a patient with MR?
It is not very common, sir. Less than 50% of patients, like
The
almost
more commonly found in encountered in patient with MR or MS? Previous history of acute rheumatic fever.
more commonly it will be found with patients of MS, sir. I think.
More commonly, it is found in patients with MR. So, the 50-60% is in MR, but MS is pretty uncommon. So, it's found like obviously in India, you'll find the histories, but
Yes.
generally, MS is uncommon comparatively. That you should know. The other important thing is the few important history that you could have brought out will be like, was she ever started on oral anticoagulation, a blood thinning medication? Because that will confirm it to be AF like.
Yes, sir.
So then your thought process can be directed towards AF totally. So
Yes.
the other important thing is like, how was her pregnancy? When was the last pregnancy? Did she have any problem during pregnancy or anything like that? Even though she's 68, so maybe her pregnancy happened long back. But
Yes.
you have any idea on that?
Yes, sir. She has had two children, sir. Last pregnancy was almost 35, 40 years back, and
No problem during pregnancy.
there was no problem during pregnancy, sir. It was both pregnancies were uneventful and normal vaginal deliveries were there, sir.
So is it common for somebody to develop, say, acute rheumatic fever at the age of 16 and now develop MS or AS right now, 50 years down the line?
No, sir. It is uncommon. Usually, patients.
Is it uncommon in the West? Or is it uncommon in India? Is it uncommon in the West?
Yes, sir. It is
So what
uncommon
is the latent period? For example,
in
what is the
India,
latent
sir.
period from say MR, AR, AS, and MS? What is the latent period from history of acute rheumatic fever?
Yes, sir. So, for the first question, sir, it is uncommon in India to have such a long latency period. In India, usually we expect MS to present at third to fourth decade and AS to present at around fifth to sixth decade, or maybe slightly earlier also. But in Western literature, usually it is said that they occur. The symptoms occur a decade later than the Indian counterpart.
So
So
in
we are also
India,
possibly getting to a
rheumatic.
transition. Sorry.
Yes, sir.
Yeah, please.
So we are also getting towards a transition. Some other states actually, rheumatic fever is almost disappearing. So possibly we are also starting to see such patients a bit like.
And that's why probably this patient also represents probably. So in India, everything is a decade early. Rheumatic, heart failure, and ischemic. All three you can remember are a decade early. That's a dictum to remember. Our coronary age, vascular age, also almost a decade older. We all have that issue also. What percentage again? So when you were asked about the involvement of rheumatic heart, what is the juvenile mitral stenosis and how is it different? You said the second decade, third decade.
Yes, sir. Juvenile mitral stenosis is usually described as presentation of MS that occurs like very early, like less than 20 years of age. Some texts describe it as less than 18 years of age. But it is different in terms that there is a lesser calcification, but it is progressive and there are higher rates of restenosis also, and there's more subvalvular pathology associated with it.
More or less.
More subvalvular pathology
PH,
associated with it.
sinus rhythm.
Mostly in
what-
sinus rhythm, and
PH?
AF is less common.
pH.
pH is more common, sir. I'm not very sure about
More
pH,
common.
sir.
So, so,
Yes, sir.
so you must remember it's like a BMV suitable case. That's how you remember. You
Right,
don't
sir.
have to cram. Where you will do a BMV. BMV is suitable case. And who coined this? This is one of the favorite question. Somebody from which institute? From Professor Ramakrishnan's institute only. So, who coined this terminology? Where was it published?
Yes, sir.
So, a lot of times, at least in DNB exam, this used to be a very favorite question often asked. Who coined it? Who modified it? SB Roy coined it, but SB Agrawal modified it. Both were from AIMS. Uh, when it was published, I think he was, I think, not a faculty when SB Roy presented it. Then, of course, he went on to be part of institute. Dr. Rama, you can just confirm that how it was.
Yeah,
And it
yeah.
was
I think
published in
it was
Lancet.
published in Lancet, like one of the very
Yes.
few where I think we have, I think, decent contribution from India is there. Takayasu and I think juvenile MS is two areas where there is reasonably good publications are there.
Yeah, I remember our examiners used to ask us this because by they was to tell us and motivate us that you need not be a professor to publish. And SB Roy was not a professor when he published, I am told. He published it before he became a professor. And then, of course, it was modified and then published. And this was, we are talking an era, pre-independence era. That's when it was published. So, with very, very high repute in that time in Lancet, it was published. So, again, it's 18 and then 20 and then 18. And then 18, it was this, it is uh, suitable for BMV. That means less calcification, sinus rhythm, severe pH, mild to moderate MR. Mild to moderate MR.
Right, sir.
When we can go
Organic
to the examination,
tricuspid.
sir.
Sorry, sir.
No, see, we are running out of time, so maybe we will go for
Yeah.
examination.
Yeah. So move to your examination. Organic tricuspid, remember 30% was previously reported. Kenare's autopsy series showed 90%. Any autopsy series, if you are asked in exam, one of the most reputed series is from KEM Mumbai. Dr. Mahajan is also with us. Dr. Mahajan, if you can share a few words on Kinare et al. Series is that we have in autopsy series from India. Arjun, as you can move to the examination.
Yes, sir.
Mahajan, sir. Go ahead. Go to examination.
Yes, sir. On examination, my patient was conscious, cooperative, well oriented to time, place, and person. On general examination, she is well built, a height of 154 centimeter, weight of 49 kg, with a BMI of 20.6 kg per meter square. The pulse was 90 per minute, irregular, with low volume, no radiofemoral delay, and all peripheral pulses were palpable. The carotid thrill was present, and the pulse deficit was more than 10. The blood pressure was measured by a manual mercury sphygmomanometer. In the right arm in sitting position, it was 88 over 64 millimeters of mercury. In left arm sitting position, 90 over 60 millimeters of mercury. And in right lower limb, the systolic pressure was 96 millimeters of mercury. Her saturations were 100% on room air, and she was breathing comfortably with 22 breaths per minute, abdominal thoracic regular. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Uh, the JVP was raised 8 centimeters above sternal angle, which corresponds to 13 centimeters of water or around 10 millimeters of mercury, with no absent A waves, an attenuated X wave, and irregular prominent V waves. On cardiovascular
So
examination,
before you go there, so a few things like generally in AF we generally report it like a variable volume of pulse. Number one. So other thing is that important whenever you are dealing with something like a aortic stenosis, what are the other things that you should report at this stage in the pulse line?
the rise in pulse and
So rate of rise like.
rate of rise in pulse. Yes, sir.
So was it a slow racing pulse or how was it like?
Sir, it was very irregular. So I could not really appreciate the slow rise in the pulse.
No, but irregular doesn't change so much of the systolic part like.
Yes, sir.
So it can change the diastolic. Anyways, if pulse is systolic, even though that volume may change.
Yes, sir.
But I think the rate of rise will remain nearly constant like.
Right, sir.
So you have to concentrate on that.
Yes, sir.
So other important thing that you said is you used a mercury manometer. So what is the current status of mercury manometers for blood pressure measurement?
Usually obsolete, sir. We actually still have it in
Why?
our
Why they become obsolete? Like they are not obsolete. Like They are still good, but why are we stopped using it? Like,
Because
are they
mercury
banned
is
for use?
yes, sir. Mercury is a toxic agent, so that's why it's usually avoided,
So
sir.
there is a lot of environmental toxicity reported with our mercury manometers,
Yes, sir.
both for the patients as well as for the doctors and the healthcare professionals. That is why it has been stopped.
Yes, sir.
So what is the currently used blood pressure measurement method?
Uh, the what we use is usually oscillometric method, sir. And an
How does
aneroid,
it measure blood pressure?
sir, it measures by it inflates the cuff, sir, and it inflates the cuff to a point where the artery is completely occluded, and then it slowly decreases the pressure till the point when the oscillations of the artery are just measurable, like just felt by the.
How does it report the blood pressure? Say, for example, you do the oscillometric method, it reports it like 88/64. How does it come to that conclusion? Like, as a
It
cardiologist, you
usually,
have to know
sir,
this. Like,
it usually accurately measures the MEP, sir, the mean arterial pressure, and then it calculates the systolic blood pressure and calculates the
so
diastolic blood
at the,
pressure.
at the mean near about the mean arterial pressure, the oscillations are the maximum. Like,
Yes, sir.
so from an algorithm, it derives
Yes, sir.
the
Calculates the
systolic and
systolic
diastolic
and
pressure.
diastolic.
So
Yes.
if
So
that
if
is the
you know the
case, can
method,
you
which of the pressure is most likely to be inaccurately measured? Mean, systolic, or diastolic by this method?
Systolic and diastolic will be inaccurate, sir. Mean
No, no,
is
not
most accurate.
mean. Systolic as measured are still okay, but diastolics are improper. No, that's one place where Dr. Ramakrishnan is asking, where still probably mercury manometers maybe
still
still
holds
hold
true?
some value.
And then my main question was that whether you understand what you're talking, like in AF, how does it work out? Like, whether in AF oscillometric methods are good enough?
Uh, no, sir. In AF, usually oscillometric methods can report can report wrong values
No, like
because
what is the most common etiology for AF in the world?
hypertension.
Hypertension. So how can you say now that hypertension measurement in AF is not accurate with modern methods? That is very unlikely to be true in logical sense. Like, so they have been now established and there are now papers on that. In AF also oscillometric methods represent blood pressure. Like, only thing is, as you said, like 5 times you have to measure and then average it out.
Yes, sir.
Okay.
So usually we try to average of 3 or 5 values, sir.
Okay. Go on.
So on inspection, the chest is normal in shape, symmetrical with no chest deformities. The apex was visible at 6 intercostal space, 2 centimeters lateral to the midclavicular line. There were no other visible pulsations, no scars, nodules, or discharging sinuses. On palpation, the apex beat was palpable at 6 intercostal space, just lateral to the midclavicular line, and it was more prominent in the left lateral decumbent position. It was felt as a heaving, sustained impulse, predominant in the left lateral position. There was palpable P2 and no other palpable heart sounds. There was grade 2 left parasternal systolic heave, and there is no palpable thrill. On percussion, the upper left border of liver dullness was at fifth right intercostal space. The left heart border was at apex. The right heart border was 2 centimeters lateral to the sternum. And the second left intercostal space was dull on percussion. On auscultation, S1 was loud and variable. S2 was narrow split with loud P2 component. A high frequency early diastolic sound, likely opening snap, was heard. A low pitch rumbling long mid diastolic murmur was heard, best at the apex with the bell of stethoscope in left lateral position with breath held at an expiration without any pre-systolic accentuation. A grade 2/6 soft ejection systolic murmur was heard at the aortic area with mid-systolic peaking and radiation to the carotids, heard best in sitting leaning forward position in end expiration and increases with hand grip. A grade 3/6 high frequency pansystolic murmur was heard at the fourth left intercostal space, which increases on inspiration. Other system examinations, respiratory system was normal in shape with bilateral symmetrical chest wall movements, and with bilateral air entry was normal with normal vesicular breath sounds and no adventitious sounds. On GI system examination, the abdomen is soft and non-tender without any hepatosplenomegaly. And on nervous system examination, higher mental functions are normal and there is no focal neurological deficit.
So, what are the findings on examination that correlate with your history and diagnosis? And what are the findings that are disproportionate to your history as compared to your clinical exam? So, what supports and what does not support?
Yes, sir. So historically, I've had complaints of dyspnea on exertion and irregular and palpitations that were irregularly fed. So the patient most probably has AF, so that correlates with the palpitations. And the blood pressure is there's some systolic decapitation and a low pulse pressure, so that probably goes towards stenotic lesion of the left side, and that also correlates with the history. My GVP is raised with absent of A wave, and there's attenuated X wave and irregular V waves. So that
So MS this correlates, AS
yes,
this
sir.
correlates. That way, if you can just we know your findings. Just say what
Yes.
is not. So what is not in sync?
So apex is down and out in this patient. So that is I was not expecting a down and out apex in this patient. So that is one finding, sir.
What can be the possible cause in MS to have a down and out epic?
Uh, Patient also has arrhythmia. Patient also has AF. Probably fast ventricular rate can lead to tachycardiomyopathy. That can be one of the cause. Patient can have associated lesions of mitral regurgitation or aortic regurgitation that could lead to LV enlargement. That could have been
So
the second
there like possibly
possibility.
the three causes. Like don't bring in. You don't have to bring in tachycardiomyopathy for that. But generally, patient can have LV dysfunction. This
Yes, sir.
AS could be underestimating the AS because of that. It could be AS LV dysfunction where LV dysfunction is worsening things. Like
Yes, sir.
so, basically, you have to say answer it like LV dysfunction, MR and AR.
Yes, sir.
That should be the first one.
Yes, sir.
Additional lesions, right?
Yes, sir. Additional reasons.
And suppose it's not a lesion. What are the other physiological causes that can contribute to this kind of a finding?
Sometimes chronic underfilling can also lead to cardiomyopathy, sir. That
Why
is
should there be downward, outward in an underfilled heart? It's overfilling on the contrary. But what can lead to a apex which is down, but a cardiomegaly is not there? Can something lead to the apex being
just like
displaced
MS
without?
sometimes causes LA enlargement that can push the apex down and out sometimes.
That will
A
push the
large
RV,
LA
no?
and RV, yes, sir.
Not then. What about
LA can
spine?
never come to apex like
Right.
Arjun, these are all like typical final area syndromes. Like LA cannot push the heart down like so much.
Spine,
LA can push your parasternal heave. Anteriorly, it can push things, but it cannot push it down and out.
kyphoscoliosis,
Structural
lung
chest
collapse. Just think of
abnormalities.
mediastinum, right?
Lung problems.
Yeah, right-sided pleural massive effusion,
Yes, sir.
collapse of the left lung, right? So those
Yes.
things should come to mind. Or anemia, severe anemia.
Yes, sir.
That's
So all your
something
hypervolumic state like
thyrotoxicosis, very not so common
So-
now. Cirrhosis, cardiac cirrhosis. It's a volume
Yes.
volume
High
load
volume
state.
states.
Yeah.
So I think Arjun, you have done a fantastic job. You have done a very good history and a thorough examination. But a few common mistakes that everybody does. Like so, for the sake of everybody, I just wanted to clarify. So at some point of time, you use the word pitch, and some point of time you use the word frequency in terms of describing the murmur. What is the difference between both? Like you go back to your next slide.
Yes, sir.
These are common mistakes that everybody makes. So our idea is to lessen these mistakes. Like
Yes, sir.
so, what is the difference between this frequency and pitch? Like
Um,
so, pitch is what you hear,
yes,
and
sir.
frequency is what you measure.
Measure. Yes, sir.
So generally, it's better to stick to the word pitch, like when you are describing the high pitch murmur and low pitch murmur. The other some common problem that is everybody says across India, wherever I go as an examiner, it's a common problem that everybody says is. So, for example, you read this thing like you said, when the breath is held in end expiration. So how do you look for respiratory variation of a murmur? Is it normal respiration? Is it forceful respiration, or is it held expiration?
Yes, sir.
When you have to report a normal variation of a respiratory variation of a murmur,
Should be
there
normal.
are three possibilities. You should report
Yes,
it in normal breathing. You should report it in forceful breathing. You should report it in held breath, like end expiration or end expiration, holding the breath. So, what is the right way to do it? Like
So normal respiration.
normal respiration.
Yes,
So,
sir.
which condition, which murmur you specifically look for held expiration?
Yes, sir. like murmur
Which
of
murmur?
MS.
No, AR, murmur of AR.
AR.
Why we do that?
Yeah.
Why we do that?
To
Because
bring
the murmur of AR, the pitch and the quality can mimic the breath sounds, number one. And number two, while doing this, you reduce the distance between the stethoscope and the
and the
origin
heart.
of the murmur. So
Yes.
there is a small lobe of lung that can be out the path. So that is the reason, that is the only murmur you are supposed to report it in end expiration.
Okay.
So can anybody put it on chat, whether we can see the chat? So any one finding that Arjun should have reported, which has not reported? At a DM level, we expect them to report.
Tech team, I'm not able to see chat questions being
Maybe
displayed. I
okay.
think they're
So
going into the
epicocarotid delay.
participants. Yeah.
Epicocardioid delay.
In
Yes.
this case, possibly epicocarotid delay could be one that you should have possibly concentrated on.
Yes, sir. Right, sir.
So what is the cardiac output in your patient like? Can you assess the cardiac output from the information that you have?
Yes, sir. I can make an estimate, sir. So the patient.
How do you make an estimate like?
Uh,
What is poor man's cardiac output measurement like?
Sir, I'll need blood pressure. So I already have blood pressure. So I know the diastolic and the systolic blood
It's a
pressure.
proportional pulse pressure.
What
Yes,
is
sir.
proportional pulse pressure?
What is it? Proportional pulse pressure? So read about it, but unfortunately, that's not validated in the presence of AS and all, but it's validated in the presence of heart failure. In HREF situation, it is validated, but maybe that should hold true in AS also. Like,
Okay, sir.
Pulse pressure divided by a systolic multiplied by 100. That's proportional pulse pressure. More than 25% to suggest cardiac output index more than 2.2. Anything less than that would not. But as sir said, it's no more true. There have been papers contrary to it. And that's why the new edition actually Brunwald mentions that it does not always correlate. That's what sir already mentioned. So Arjun, go back to your diagnosis now based on these in the interest of time. So go to diagnosis. What do you think is your diagnosis now?
Yes, sir.
So based on this,
Yes, sir. So the diagnosis on the basis of history at the end of it, history examination, I made is a 68-year-old female with the valvular heart disease of rheumatic etiology in form of severe mitral stenosis with moderate aortic stenosis, moderate TR with moderate PAH, moderate PVH in atrial fibrillation with controlled ventricular rate, in heart failure, NYHA class 2, with LV systolic dysfunction, without evidence of active rheumatic heart disease, active rheumatic disease, or infective endocarditis.
so one thing is like she is admitted currently with the class 4 symptoms, I suppose.
Yes, sir.
5 days back.
Yes, sir. 5 days back. Yes, sir.
So then don't make it class 2. That's a big thing. Like suppose somebody is admitted with decompensated heart failure in 5 days back, you cannot allow the class 2.
Yes, sir.
So that's one, and then possibly she should have severe PVH then.
Yes, sir.
So severe PVH, why? Because you are on one end claiming she is LV dysfunction, and the other end she is having severe heart failure, and then she is admitted with class 4 symptoms like.
Yes, sir. Yes, sir. Definitely severe PVH, sir.
Why you want to bring in LV dysfunction?
Mostly, sir, because of the apex, because it was down and out. So I was thinking maybe LV enlargement is there. So that is one reason, sir. I could not find an additional murmur or any additional finding that could point towards a lesion that could lead to LV enlargement.
Why do you
all
say
right.
it's moderate AS like?
Yeah. Clinically, why moderate?
Clinically, sir, one thing was that there was no I did see actually epicocarotid delay. I did not mention it, and the murmur was also mid peaking. It was not late peaking as as I've seen in.
I got patient. Why you think the patient is having LV dysfunction?
Yes, sir.
If there is controlled ventricular rate, and why the patient should be having LV dysfunction? So you all know from your echo that LV dysfunction can reduce the gradient. So same thing should happen to the murmur.
Yes, sir.
If AS is severe enough to produce LV dysfunction, this should be severe.
Yes, sir.
That is why rate of rise of pulse is very important in this case.
Right.
If you have a slow rising, late peaking pulse, then you should confidently put this is going to be like either even if the murmur is a short like mid peaking murmur, if there is associated AS with LV dysfunction will be there, definitely the pulse is going to be further delayed. Like
Yes, sir.
slow rising, late peaking, typical Paras et tardus is there, then you can confidently say this is there. Other finding that you have is a narrow split. Like
Yes, sir. So yes, sir. Narrow split is there. That also point towards severe yes. Although it could
another
be.
thing that you didn't say about is A2OS gap, like in the MS part, like.
Yes, sir.
Maybe I missed it, like whether you said.
Sir, I mentioned long murmur, so it had a short.
How do you assess it in AF, like A2OS gap, like A2OS gap in AF?
Yes, sir. Usually, AF has irregular
because
cycles.
A2OS gap is very important for your MS severity assessment. How do you assess it in AF?
So I'll assess it in long cycles, sir. In short cycles, it'll be difficult to get the A2OS gap. So in long cycles, if I'm getting a long murmur, with the usually the range is with the adequate exposure in an inspiratory film that shows cardiomegaly, a straightening of the left heart border with splaying of carina and probably a double contour sign on the right side, which is indicative of cardiomegaly. Probably LA enlargement is there, along with increased bronchovascular markings, predominant in the upper lobes, but also present in the mid zones. So probably with Hyler haze, so suggestive of cardiomegaly. This is corresponds with mitral stenosis with LA enlargement and severe PVH, and because of straightening of the left heart border, also probably because of enlarged pulmonary artery, and I cannot appreciate any calcification of the aortic valve or at the level of the mitral valve.
So remember, always the distal lesion mask the proximal one, or the proximal mask the distal one.
Yes.
What is it, Arjun?
Proximal mask the distal one.
So the findings would that way be explained, right? Your
Yes.
aortic stenosis and mitral stenosis, how this is coming in. And X-ray findings, what does it corroborate now? What do you think? This is still dominant mitral valve disease or a dominant aortic valve disease from an X-ray?
Predominant mitral valve disease, sir, because I can see an enlarged LA, straightened left heart border, and then PVH is also there predominantly. So predominant mitral valve disease.
Again, distal is masked by the proximal. MS is actually probably masking your. So despite MS, if you're getting the carotid, apicocarotid delay or other findings, this AS is coming out despite being masked, right? So
Right.
probably you're dealing with a very. I'm not saying MS is not severe. There are findings. There is straightening. There is cardiomegaly. RV tip XLA is out. Double contour is there. There is upper lobe redistribution. But you look at the aortic knuckle. There is post-aortic dilatation, right? Aortic knuckle is dilated. Surely there is some amount of significant aortic stenosis. Dr. Ramakrishnan?
Yeah, agree, sir. Agree. Even the apex looks clearly LV like.
LV.
This is definitely significant AS is there.
Yes, sir.
Can we confirm that on ECG, Arjun?
Yes, sir.
So what are you expecting now? How would you say this is probably, which one finding would tell you AS dominant versus MS dominant in this ECG?
I want to look at LVH or RVH, sir.
How would you define that?
So in RVH, I'll be looking for V1 to see.
So it will be the nullifying two forces.
Yes.
What
sir.
will tell you which dominates? The axis.
Axis.
Look at the axis, right? So what is the axis?
It was leftward axis, sir. It is normal axis, sir. Mostly around 30 to 40 degrees, sir. Because I can see that lead 3 is probably equivalent, and lead 2 is not having prominent S waves.
So you don't expect in severe MS, you actually expect more of a rightward axis, right? So again, that goes on to say there is good amount of stenosis, which is still keeping the forces to the left. Even if you look at the lead AVF, it's low voltage. And no, so when you have this kind of an ECG, what is one new differential from the new disorders that creep in your mind? Low voltages, an aortic stenosis that you should think of with atrial fibrillation.
Yes, sir. Amyloidosis or restrictive cardiomyopathy is
Always think of amyloid as a cause of
amyloidosis.
aortic stenosis. In recent series, including in TAVI, they found out what is the percentage now in amyloid and senile aortic stenosis. What percentage patients actually are coming with amyloid now? Now, previously, what was thought as 1 or 2% is now 15, 20%. Huge number, right? 15 to 20% in autopsy series have turned out to be cardiac amyloid, especially in elderly who present for surgical AVRs. The histopathology, when it is sent as an post-operatively, amyloids are being diagnosed very often. So low voltages, precaudal leads. But again, you will probably look at pseudo-infarction pattern, which is missing here. That's the classical of a myeloid. But again, that's one differential you should keep in mind.
Yes.
So access, voltage, no RVH, low voltages, atrial fibrillation, fast rate. And anything else?
Um,
What is this 456 STT changes?
yes, sir. It's not associated. It is not accompanied with LVH, although it could be non-specific also sometimes in
Or
females. Or
can it be with drug, some drug?
yeah,
V4, slightly, maybe not.
yes, sir. Digoxin sometimes
Digoxin
causes. Yes, sir.
sometimes
Digoxin.
can cause. And reverse tick sign, not a classical one here. But
Yes, sir.
maybe this patient is on digitalis, you never know. Rama sir, any other question? I will move to
Fine,
echo.
fine. This is fine, sir, I think.
Go ahead to echo quickly because we have sir's expert talk. Yeah. So can you play them?
Yes, sir.
Okay, fine. Go
Yes, sir.
to
So this
keep
was a
describing and keep moving the slides quickly. Yeah.
yes, sir. Echo Plaques view. This is the M mode, which in which on the top image you can see the moving image of thickened mitral valve, anterior mitral leaflet with thickening of the tips and increased motion of the anterior mitral leaflet and fixed PMVL. On the at the bottom with the M mode, we can see that the EF line is flat, and there's a paradoxical motion of the it is not very well visible here, but PMVL is not moving. Um, on applying the color Doppler, I wanted to see whether there is any mitral degradation. So mitral degradation was a significant mitral degradation is not present, but I can see that there is a thickening at the level of aortic valve also. So aortic valve leaflets are thickened, probably calcific and with decreased motion.
Go ahead. Look at
And there
the
is also
Go ahead. Look at the
yes, sir. And there
other
is
view.
some yes, sir. This was the modified short axis view, in which the en-face view of the aortic valve, and I can see that there's thickening of the aortic valve with some commercial fusion. And herein there was a short axis view at the level of the mitral valve with the area by 2D planimetry was around 1.1 centimeter square. And this was a short axis view for the LV function, which LV function is probably normal. And there
the
was
aortic
some
gradient, if you can just quickly come to them. Yeah.
yes, sir. This was
So
the
biatrial
PST
enlargement.
across.
Do you think it's biatrial enlargement?
Yes, sir. There is
Can you
biatrial
have mitral
enlargement.
stenosis with amyloid? Can amyloidosis
Yes, sir.
cause mitral stenosis?
Um,
Yes or no? It can. But
can be
then
associated
you will
with
not have this
degenerative
kind of a
disease.
feature. Subvalvular pathology. Yeah, that doesn't happen. It's a rare cause.
Yes, sir.
Okay. Next, aortic.
Yes, sir. Yes, sir. So these were the gradients across the aortic valve. Um, there was some aortic regurgitation, and the gradient across the aortic valve, the peak velocity was around 3.8 with a Vmax of around 38 millimeters of mercury. And this was the LVOT Vmax. And I did calculate the aortic valve area by a continuity equation. That came out to be around 0.4 centimeter square. And this
That's
was
the severe AS, right?
yes, yes, sir.
Good that you
And
stayed honest to your findings rather than jump to a point 0.4 area of aortic valve. But that explains a lot of stuff as to why you were getting what findings, right?
yes,
You had a good significant amount of two regurgitant lesions. The Doppler signal for the AR surely doesn't look purely mild. It looks more than mild.
yes,
If you look at the vena contracta, even the otherwise, the LV size, it's not so small as for that for a severe MS or purely AS. So findings are in favor of a good significant amount of regurg, and that may be responsible for a palpitation and volume overload. So,
yes.
what's your plan for this patient?
Sir, advised for surgery, sir. So,
No, so
want
don't
to,
jump to that's a common mistake. Always
yes,
say I will work up, look, rule out carditis, anticoagulate, decongest. वो सब भी बोलना पड़ेगा ना. You cannot jump to surgery or jump to
yes, sir.
BMVs in these cases
Medical,
because
yes, sir.
we all know you'll do all that, but then
Yes,
uh, all the examiners are very much averse you just becoming a pure interventional guy. Always think of
yes,
medical management and think about that optimization because that has to be preceded as well as followed up, right? So always rule out carditis, anemia, decongest, anticoagulate, rule out other disorders associated with it, and then only think of suitability as to what the patient would undergo. So what would that be? Can you do a TAVI or a BAV? BMV plus BAV?
the patient has mitral stenosis also, sir.
Yeah,
So,
BMV plus BAV, I said. You can do both balloons.
yes, sir.
Can you?
What is the difference of BAV in rheumatic heart disease?
Uh, Not sure, sir. PAV is usually done in degenerative aortic
Is it
stenosis.
done? In your institute, do
Now,
you do BAVs in rheumatics?
uh,
You don't.
yes, sir.
The results are not so good, na? Sir is
Yes,
asking.
yes, sir.
So there is a series from JIPMAR that they have published relatively younger patients with rheumatic AS. You should read about that.
Yes, sir.
So in terms of heart rate control, what are the agents that you'll go for and why?
Yes, sir. So, I'll go for beta blockers, sir. Patient is having so it has effect on cardiac remodeling and has uh, decrease in heart. It reduces both the resting and exercise heart rate, sir.
You said digoxin. What is the current data on digoxin in rheumatic heart disease?
Uh, there is a new publication, sir. Digit HF is there and DIG trial is also there. So they favor use of digoxin in.
In rheumatic?
Yes, sir. As far as I'm aware, sir.
Any recent publication you are aware of?
This digit HF trial, sir. But for rheumatic, I'm not aware, sir.
There's a very few Indian papers are there. I should know about it. It's from India, multi-center study, recently published, like digoxin in patients with symptomatic rheumatic heart disease by one of my colleague, Dr. Karthikeyan. So it's published in JAMA. It's a massive
Yes,
trial, like, so I think all of you should be aware of it. Like,
yes, sir.
so almost nearly around 1,800 patients study, where there is a significant clinical improvement and outcome difference with digoxin in rheumatic heart disease. So what about ivabradine in patients with AF and in patients with sinus rhythm in MS?
In patients with AF, ivabradine is not usually considered, sir. In sinus rhythm,
So it has been, there are again data on this, like ivabradine compared to beta blocker in rheumatic MS, especially for symptom improvement and the heart rate control. That is there. That I think you should be aware of. There are some at least 3-4 good studies are there. There is a placebo, like double-blind studies also there from GV Pant. That study is from GV Pant. The other important thing is now when you're up against this, you're not able to control heart rate with many agents, and ivabradine has been nowadays used to control heart rate in AF.
right, sir.
So bioprosthetic valve, or when you go for DVR, bioprosthetic valve or mechanical valve?
Um, She's 63 years age, sir. She already has AF, so she will probably need anticoagulation. So I'll prefer mechanical valve. Uh, Although the data for mitral valve supports says
What is the
that
current data on, like, what is the age cutoff for choosing a mechanical valve over bioprosthetic valve? Even if she is having AF, does the quantum of anticoagulation or use of Novax change with bioprosthetic compared to mechanical valve?
uh, so, sir, it
Suppose
is
you do a bioprosthetic valve, so after what time you can use a Novac in her? Because you know from history and the way you presented, her chances of defaulting and not being regular on oral anticoagulation is fairly high.
yes, sir. Yes, sir. Um,
So, what is the age cutoff like in the current ESC guideline, like in choosing a mechanical over bioprosthetic? Like,
Yes, sir. They're different for mitral valve and aortic valve, sir. Usually 55 to 70, less than 55, we consider for.
so I think read about all this, like read about all these issues. So
Yes, sir.
I think sir, maybe we can. Uh, sir, you're muted. You're muted.
Yeah, we can, I think, now move to our presentation in the interest of time to hear best from the expert. Arjun, it was a fantastic presentation. I hope it added to your learning, and a lot of students have joined in. There are a lot of questions, sir. If the time permits after your talk, we'll take those questions. Thank you, Arjun, for presenting. And now I invite my dear friend and colleague, Professor S. Ramakrishnan, Professor Cardiology, to take this through with the approach, clinical approach in a case of multivalvular heart disease, how a resident or a clinician should approach a case of multivalvular. Over to you, Dr. Ramesh.
I think before I start my presentation, I think give Arjun a big hand. I think he did a fantastic job, which I think far more stressful than even examination to present among say 500, 700 patients or colleagues across India. It's not an easy job, and fantastic job, Arjun. Keep it up.
Thank you, sir. Thank you,
Okay.
sir.
So I think I'll move over to approach to a patient with multiple heart disease. So many of you wonder, like, eras have changed. We have moved on. The cardiology has changed from the era of auscultation. But still, why are we sticking to multivalvular heart disease? It always remains an examiner's delight and an examiner's nightmare because that is how most of the examiners look at it, a rheumatic heart disease case in the exam. But in my opinion, it's actually a primary test of synthesis. As a doctor, as a cardiologist, you come across a lot of gray areas. It is not always black and white in our life. So many of the things are actually gray. We want to know how much importance you give to a particular finding, your particular sign or a particular angiography finding or whatever be it like. How much importance you want to give, how do you interpret it. And RST many a times brings out a lot of these lacunae or insufficiencies. And then how do you synthesize your whole case becomes very important. Right? So as, even in this case also we are not bothered about what exactly we found in echo, but we should be true to what you find in the clinical examination. So a simple flow chart that I think many of the things that I'm going to talk are I think mostly known to a DM level student, but this I feel every one of you should know. So so among the sore throat, so roughly around 4 to 6 attacks per year up to 10 years of age, out of which roughly around 20% are streptococcal. So 50% are asymptomatic carrier and asymptomatic, and then 25% carrier state can be there. Out of the streptococcal sore throats, 0.3 to 3% develop acute rheumatic fever. If this is endemic of streptococcal sore throat or it's an epidemic of streptococcal sore throat, that is where the 0.3 and 3% difference comes up. Out of this, how many develop RST? So that is roughly around, if you look at it, roughly around 20 to 30% develop RST. So it's a simple flowchart that you can keep, and then you can read about how many acute rheumatic fever will have carditis in terms of clinical, subclinical, all those things you can read about. So what are we assessing? I think Arjun completed all the essential elements of a diagnosis. So not only the severity, but we want to assess other things also. Like so, the 9-point complete assessment should be severity and combination of valve lesions, in the NHA functional class and heart failure, rhythm, PVH, pH, LV function, features of carditis, features of IE, and precipitating factors. So these all form the 9 factors for assessment. So I often teach so when in exams you find quite a lot of time most of the time, especially if you're not the first candidate going into the exam, you find a lot of things. You always make a habit of 9 boxes so 9 boxes that you have to concentrate are the in the general examination, at least in your mind, you should make these boxes so the pulse, JVP, and blood pressure in the general examination, and before you put your stethoscope, apical impulse, parasternal heave, and presence of thrill, and in auscultation, heart sounds, added sounds, and murmurs. So these 9 points should correlate with whatever diagnosis you are coming up with. So these 9 points should correlate with the 9 things that you are actually suggesting. So it's actually 9 by 9. So if anything is not fitting in, like for example, in the last case, whatever diagnosis Arjun was putting up, the apex heaving apical impulse, which is down and out, was not fitting in. So that's why he put in LV systolic dysfunction. So you have to think like this and then put everything. Whatever is not matching, mixing, that you should be the one who is pointing out when you are presenting rather than examiner being pointed out and you feeling stunned in the examination. That is what is the difference between an DM examination and an MD or an MBBS examination. So everything is going to remain the same. Apical impulse is going to be heaving or tapping in MBBS also, in MD also, and in DM also. What is the exact difference we are looking at in a DM candidate is your ability to understand the natural history of the disease, your ability to understand the hemodynamics of the disease, and your ability to understand the basis behind all these symptoms and signs that you are able to elicit. So that is how the DM examination is different from an MBBS or an MD examination. So you should always get into the habit of comparing these 9 features that you are describing in your final diagnosis with these 9 classical signs that you should focus on. Rest of them are minor, like only the cardiology relies on these 9 signs. So coming to severe MS, how do you say severe MS? It's actually a prolonged diastolic murmur with presystolic accentuation. There is to be a thrill, presence of a thrill, A to OS gap most of the time, pulmonary hypertension, cardiomegaly, and congestive heart failure if they are associated with an isolated lesion. Presence of AST, intensity of the murmur, and presystolic accentuation per se do not correlate with severity of mitral stenosis. So in a multivalvular heart disease, when there is everything is at a problem, then mostly these things will disappear. These things won't help you. So A2S cap also can be, there are some fallacies that can be there. So presence of a thrill and a presence of a prolonged diastolic murmur will always indicate a severe MS. So in terms of OS versus S3, that becomes very important for differentiation. How do you differentiate opening snap versus S3? Opening snap is heard everywhere, whereas S3 is localized, LVS3 is localized to the apex. The intervals are given here. The pitch is high-pitched opening snap, whereas low-pitched is S3. And the postural variation widens on standing, S3 doesn't change. Coming to severe MR, what are the factors suggesting severe MR? Presence of cardiomegaly, LVS3, and a diastolic flow murmur, wide split S2, and some textbooks describe thrill as the presence of a thrill, a systolic thrill at the apex as an indicator of severe MR. But we have all seen that, especially anteriorly directed death, even a moderate MR in lean, thin individuals, especially adolescents that we see in India, you can get a thrill. So LV systolic dysfunction, pulmonary hypertension, and congestive heart failure, all of them can be there. For example, if the patient has AR and MR or a multivalvular heart disease, which are the ones that are going to stand back, which are the will disappear, which will not tell you. Like for example, if there is a AR can also produce a Austin Flynn murmur. If there is MS, that can also produce a diastolic murmur. So what will stand out is a wide split S2. A wide split S2 in the presence of multivalvular heart disease, in the presence of MR, you can safely bet that the MR is severe. Severe AR, the important ones are Hill sign, the duration of the diastolic murmur, presence of an Austin Flynn murmur. Thrill is extremely rare, but if there, definitely it indicates severe AR. Cardiomegaly, LVS3, LV systolic dysfunction, pulmonary hypertension, and congestive heart failure in aortic valve disease are extremely rare and end-stage disease unless it's an acute AR. So we are all discussing with mostly chronic presentation here. So what are the ones that are going to stay back? These are the ones that are going to stay back. Hill sign, the duration of the diastolic murmur, Austin Flynn murmur, and the presence of a thrill if it is there. So Hill sign, we all know that how do you grade Hill sign, but Hill sign may be falsely low in LV systolic dysfunction, acute AR, and if there is associated AS. But Hill sign, there are a lot of fallacies about Hill sign, whether this is actually a true sign or it's an artifact. But primarily, it is now people think they start to think that it is more like an the sphygmomanometric artifact. You can read about it in extensively. There are a lot of articles happening there, but still it's a useful clinical sign which may be useful in assessing severity of AR. So AR murmur, if it is heard on the right side of the sternum, it indicates aortic root pathologies like aortic aneurysm, cystic medial necrosis, syphilis, idiopathic aortic aneurysm, sinus of valsalva aneurysm, aortic dissection, and selective perforation or eversion of the right coronary cusp. Severe AS, the most important thing is pulsus parvus et tardus, peaking of the systolic murmur, paradoxically split S2, S4, epicocarotid delay, which is often neglected, thrill and cardiomegaly, Elvis dysfunction, and pulmonary hypertension and congestive heart failure, as I told you again, these are all extremely rare in aortic valve disease isolated. But here, many of the things may stand out in the case of multivalve heart disease also. But as we discussed last time, many of these findings can be masked by a tighter lesion like an MS on the other side. So things that stand out in a patient with multivalve heart disease, especially the pulse. The pulse in aortic valve disease, pulsus parvus et tardus, or the collapsing pulse, the Hill sign, the murmur characteristics, except in MR. So many a times I find like MR, the murmur characteristics are not fully described. Like for example, MR, every murmur is going to be pansystolic. So in AS, the murmur is very, very important. The duration of the murmur, as well as most importantly, the peaking of the murmur is what is important. The duration of both the diastolic murmur, MS and AR murmurs are extremely important. When you are describing, you should emphasize the important findings first. Diastolic thrill is very important, and paradoxical split S2 in AS and wide split S2 in MR always stand out in the presence of multivalve heart disease. And A2OS gap mostly stand out, but there are some problems that happen with A2OS gap assessment. Some rule of combined valve lesion that we discussed. So severe lesions tend to dominate. The proximal lesions tend to dominate. TS protects and masks a mitral valve and aortic valve lesion. As we seen in the last case, severe MS may mask the aortic valve lesions. So other important thing is multivalve disease, 1 plus 1 may not be 2. So that because of the ability to compensate is there. So some of the important one, if there are important differences that all of us should know is in the presence of AR, is there MS like so because you find a MDM, whether that MDM is because of MS or it's because of an Austin field murmur. The MS murmur is generally prolonged with the thrill. The apex will be RV with tapping apical impulse. Opening snap will be there. PH signs will be there. S1 will be mostly loud. AF is suggestive, and it decreases with hand grip. Whereas the opposite true in most of the things in Austin field murmur is a soft, short murmur. LV apex, which is hyperkinetic, it can be have associated with S3, mild PH, and it will increase with hand grip. PS is something that easily escape attention, more fatigue, heart failure, less PND and orthopnea. JVP is the key. In the absence of AF, giant A waves are shown and then slow wide descent. Pulsatile liver, armor of TS is characterized by the location, the presystolic, the mid-diastolic features determine the severity, and the inspiratory augmentation should be there. In terms of TR, if there is a severe TR, whether you want to know whether it's an organic tricuspidal disease, it's a high pressure TR or a low pressure TR of organic tricuspidal disease. Fortunately, this has become uncommon or less common in today's time, the low pressure TR and rheumatic. But oftentimes you may encounter, especially in a post-operative patient, sometimes these patients are kept in your exams, like patient had undergone a mitral valve procedure, now has come with right heart failure with severe TR, where it could be actually low pressure TR. So the important difference are the pitch of the murmur is high pressure, TR is high pitch, low pressure TR is low pitched. The murmur is characteristic PSM in high pressure TR, whereas it's an early systolic. Remember it like Epstein murmur, like early systolic murmur with variable duration. The shape is pan-systolic, whereas here it is decrescendo. The signs will be the P2 will be there, and then loud P2 will be there. Low pressure TR will be normal. JP will have CV waves in high pressure TR, whereas low pressure TR will depend on the etiology. For example, Epstein it may be normal, but in low pressure rheumatic TR, you will find CV waves. So this is the pH classification that all of you should be aware of. So how do you classify in children? I think you should be all aware of. And then PVH classification is the various grade 1, 2, 3 in X-ray also you should know that. So what are the signs of PVH? Because many of you falter in categorizing PVH and pH in a rheumatic heart disease case. So the signs of PVH is parasternal, left parasternal heave 3/3 generally indicates severe pH. In the absence of an RV volume overload of, for example, ASD, Rest of the situations, it always indicates severe PH, or very rarely it could indicate an LA enlargement because of a severe MR. Rest of the situation, it always indicates severe PH. A loud P2, which is palpable, generally indicates severe PH, except with the exception of ASD. How do you know it's a loud P2? You compare it with A2, whether it is heard at the apex, whether it is palpable or not. Other signs of severe PH include RVS3, S4, a constant ejection click, murmur of TR, ejection systolic murmur, and murmur of PR. So if you find a PR, which is not common in rheumatic heart disease, but in congenital heart disease, you may find there also you should differentiate between high pressure PR and a low pressure PR. Again, high pitch versus duration, longer duration, associated signs of pH will be there. So this is another common mistake that many of you encounter or make it. So how do you assess pulmonary venous hypertension in a given case? So whether you say mild, moderate, or severe, so it all depends on the symptom class number one. Presence or absence of pulmonary edema, significant decompensated heart failure, you always say it's class 4. Severe PVH is there. Cardiomegaly, presence of cardiomegaly. And two important things that I think this concept has to be clear. You have to make an estimation from RA pressure estimation. So, for example, if your RA pressure is very high, the patient is in gross heart failure. So, if it's a predominantly left side heart disease producing such a significant right heart failure, the pulmonary venous hypertension has to be much more than your RA pressure. So, without that, blood flow cannot happen. You have to think like that. The other one important is, for example, if somebody, this same patient, for example, severe MS is there that is producing severe PAH, then obviously severe PVH has to be there to produce that severe PAH. So that is the kind of numbering that you have to do. And same way, if somebody has moderate pH also, so you have to do the numbers. Like you have to think in terms of the numbers that I showed you. What is the moderate pH number? Then look at how much PVH has to be there to produce moderate pH. So moderate pH cannot be produced by mild PVH. So this kind of estimation has to be there. So in nutshell, the estimation of PVH in a multivalent heart disease should depend on the symptom class, the pulmonary edema, or the class of the patient, and the acuteness of the history, the cardiomegaly, from your JVP estimation and from your pulmonary artery pressure estimation. So PND is always class 4, orthopnea is, so PND is not class 4, orthopnea is class 4. Atrial fibrillation modifies the clinical findings. S1 is variable. The diastolic event, MS and AR assessment is what produces the experience. So it has to be associated with a normal LV systolic function. So other important ones are sustained apex in a volume overload and a dilated heart with a diffuse apex in a pressure overload, pulmonary venous hypertension, arterial hypertension, then right heart failure. But early and disproportionate heart failure in the presence of valvular heart disease, you should think of these conditions like organic tricuspid valve disease, Rutenbacher syndrome, RSOV, EMF or CCP, or other precipitating character problem in your diagnosis and what you are finding in these 9 signs. If you know the basic fundamentals and put the pieces together, I think multivalent heart disease is extremely easy to score well and do well in your exams. But one critical important step is don't do this practice just for 3 months before your exams. Do this practice for the whole 3 years. So every day, whatever patient you see in your OPD or echo lab is the best place. Echo lab, you do the echo, see the patient with multivalent heart disease. So you know this patient is multivalent heart disease. You first do the clinical examination, simple, basic, cursory clinical examination. Pulse, don't even take the blood pressure. You take the pulse, you check the JVP, you do the apical impulse and the parasternal heave and palpable events, and put your stethoscope. So you make up your mind what you're finding, and then do the echo. And if your echo is significantly different from what you found, then go back and auscultate again or examine again. So this way, your comprehensive evaluation pattern will become a lot better. Major problem that happens in the exam current era is that nowadays you concentrate only for 3 months. Just when your thesis is over, then you start working on it. Like I think give it 3 years. One patient per week is good enough to train you in all clinical cardiology. And always learn from your echo. So thank you for patient listening.
Thank you. Thank you for a wonderful talk, Professor Ramakrishnan. Wonderful as always. And you had actually summarized it. I've heard your this talk in one of the other forum, but again, no repetition. You created completely, which was in the format which was required. And you still left us with 5 minutes of question answers from the participants. And a lot of questions. We had a wonderful audience, huge amount of people who have joined online. But I think for the interest of time and to finish it on time, I'll just take the few of them which are there. Dr. Kanthil has asked a lot of question. He is mentioning also about percentage. I think we answered a lot of them. Dr. Anamika is asking if you can take Dr. In presence of heart failure, what will be the character of apex beat? So,
So
like this
apex beat,
case, we were looking, yeah, apex beat. So, I think probably they're trying to refer the heaving character of apex in a patient of MS. If you get heart failure, say, what would be the character that should be described of apex beat in a patient with heart failure?
so in MS, the LV is absolutely normal. So in MX, LV is going to be normal, so or it's underfilled. So you cannot have a dilated apex or a diffuse apex. The diffuse apex or dilated apex that happens in MS is going to be because of an RV failure. So it has to be a RV. It has to be a outward shift, not a down and out shift, and it will be a diffuse apex of RV. But whereas in MR and AR, the moment heart failure comes up, so this will be like a really down and out apical impulse, which is volume overloaded type, but they may become sustained. So LV apex are generally localized, but a diffuse apex can happen in this situation. And a diffuse sustained apex is generally indicative of volume overload state turned into a LV systolic dysfunction, or the other way around, a concentric LVH, which should have been localized in a normal position, which is heaving, now has dilated and gone down and out in AS with LV dysfunction, for example. So it will be different for different etiologies or different
Right.
valve pathologies.
Right. A lot of questions from other participants, active participation by Dr. Anamika, Dr. Kanthil, Dr. Aditi. There's one question from Dr. Alok Ranjan Pradhan who's asking, what if we use bioprosthetic valve in this clinical case that was presented by Arjun and then start Novak for AFib so that you don't need to adjust INR? If you would like to answer that, that's a
Yeah,
very
I think
important.
my personal preference would be that like 68-year-old, I will definitely put a bioprosthetic valve, mitral as well as aortic, for two reasons. One is that there is plenty of calcium, and then generally bioprosthetic valves are a bit more forgiving when it comes to paravalvular leaks. And obviously, it's just a patient who has been having a history of drug default and everything. We don't want to take a chance with anticoagulation. So I think the quantum of anticoagulation is not going to be so severe in an elderly patient if you're just treating AF compared to a DVR with AF. So I think maybe for 3 months oral anticoagulation followed by 3 to 6 months, depending on the valve that has been used, oral anticoagulation followed by Novak will be the right way to go.
Right. I think Invictus trial showed us that it doesn't work in a metallic valve. So Novaks are completely no-no in a prosthetic valve for sure. Bioprosthetic, I think it's really a gray area, as Dr. Ramakrishnan mentioned. We can have both ways. But again, the question that would come back as to how the rheumatic LAs and LA appendages do behave. One of the hypotheses is that the appendages are not really something that are good to anticoagulate. And probably that's why people talk about why Novak versus VK versus Watchmen. There are a lot of negative trials for Watchmen now coming in. It's probably another gray area. But I think when you're putting a bioprosthetic both at mitral and aortic, we definitely need to discuss with the patient as to how long these biological valves are going to last. If their expectation is a lifelong, probably that doesn't happen. Most of the biological valves tend to degenerate. The rate is almost 20 to 30% over a decade, especially in the mitral and aortic if you put two of them. So if you explain that probably and then put that strategy, that would be nice. But I think you'll have to be open, and this is an interesting question. And as Dr. Ramakrishnan mentioned, that's one other strategy that can be thought of. Any comments, Dr. Ramakrishnan? And
I
otherwise,
think I agree with you. I think it has
okay.
to be patient-based decision. She's a heavy worker, so if she wants to go back to heavy work, I think both way there could be valve degeneration, which could be faster. If she's relatively well preserved, I think that also becomes a factor. Like.
Right. I think a lot of students are asking, Shivam is asking, sir, teach hemodynamics, take cases for the spotters. CSI would surely, headquarter would be interested in taking care of this. And this link, which is there, will remain with you guys. We are ending the timeline for the day. But remember now that for this video, tech team is going to make it available for those who have missed out the session. They can join the link for the video and attend this lecture as well. Every fourth Saturday, we are going to have one expert faculty like Professor Ramakrishnan who will be taking us through. The next one one hence falls on 25th of July. And we'll have Professor Saurabh Gupta, who's again from AIMS, to take us through shunt physiology. We'll be discussing a case of shunt physiology, and he'll be taking us the clinical approach of approaching a case of shunt physiology, which is really on 25th. So you can intimate those who have missed out and can join us. Let me have comments from my colleagues. Dr. R.K. Singh. Dr. Singh, are you there? And
Yeah, I'm there, but light was,
oh yeah, I
interrupted
could
me.
see that.
So,
Yeah, yeah.
it was he presented, Arjun presented this case was very efficiently, and we all admire that presentation because it will create a history with the other students. And Dr. Ramakrishnan has very nicely put forward important points which we should not forget during examination, especially if we keep that 6 and 9 things together in the mind. So that's all what I want to comment. I think this will
Thank
make
you.
a lot of difference. Thank you.
Thank you for being there. And I think Dr. Ajay Majan probably just logged out. He was also there. So thank you, Dr. Ramakrishnan. Thank you, CSI headquarter. Thank you, my support system, and Dr. Arjun for presenting the case. We look forward to have you all guys again, fourth Saturday, 8 p.m. every month for the 5 episodes, for the 5 important clinical cases. And then we'll also try to cover the spotters and the images with an expert talk on that same. Thank you, everyone. Take care. Good night. Thank you,
Thank you,
Dr.
sir.
Rama.
Thank you.
Thank you
Thank you
very
for the
much.
opportunity.
Thank you. Thank you very much. Bye bye.